Good afternoon. I think we'll get started for the afternoon session. Good afternoon, everyone. I'm Bill Hoagland with the Bipartisan Policy Center. We're here on the last session of Medicare, on the Medicare track. We're supposed to find consensus on Medicare reform. We'll see how successful we are. We may have, this panel may have drawn the short straw in this conference, trying to identify consensus points and the framework that flowed out of the two panels that participated yesterday on Medicare. Some of you who may have been here know that the first panel described the basic principles upon which reform should proceed. And the second panel was to review various competing reform proposals, and this panel is going to pull it all together. But let me try to set the stage a little bit for this panel and give you at least my takeaways from the two panels of yesterday. The first is simply, regardless of the recent 2012 a slowdown in Medicare spending per beneficiary, healthcare cost growth still remains an issue, and we still spend more than most in developed countries at 18% of GDP. So for the purposes of this discussion this afternoon, we're all going to simply agree with the President of the United States and something he said on January the 1st, which he said, "The aging population and rising cost of health care makes Medicare the biggest contributor to our deficit." And he went on to say, "I believe we've got to find ways to reform that program without hurting seniors who count on it to survive." So let's all agree to set the parameters here. Let's all agree we have a problem, and that, like it or not for some NASI folks, it will be driven by the budget constraints in the near term, and we are going to have this debate in the 113th Congress, whether some of us think it is necessary or not. That's my first takeaway from yesterday. The second takeaway, the Affordable Care Act is here to stay. Get over it, work with it, build on it, and move on. I think the principles that Bob Reichar laid out yesterday in terms of universal eligibility, guaranteed issuance, renewal, access to mainstream providers, choice, quality, affordable benefits similar to ESI, all those apply. The third takeaway, I think, is that generally it was agreed that the current Medicare payment system rewarding quantity of services delivered over quality, that is a costly and inefficient payment mechanism, and it needs to be replaced, but with what? The fourth takeaway I took was that, looking back years ago, we thought that converting from a cost-based reimbursement to a prospective payment system was the magic answer for controlling costs. In the 1990s, we thought managed care was the answer. Now, pay-for-performance and consumer-driven health care has been advanced to control cost. And now we all hope rises that the integration of care, the adoption of hospital and doctor salary-based payment models, or the bundling of payments and other innovations, that will somehow drive cost. I think the answer is we don't know. And finally, the fifth takeaway I took was from one of the questioners yesterday, I believe it was Professor Marmon from Yale, who forcefully challenged, I think, some of the presenters that there would be no cost control, that cost control will not work, as I think he phrased it, unless there is countervailing power brought to reduce, and these are my words, I think I'm saying what the professor said, unless that countervailing power reduces incomes, profits of hospitals, doctors, pharma, nursing home operators, and many other stakeholders. Somebody has to give up something, and if there's to be true cost control. And these are my words, not the professor's words, but we have what I think is a medical industrial complex that is threatening to our country's future, and maybe in the same words as President Eisenhower's words that admonished us about a military industrial complex in the 1950s. And just interesting as a sidebar, since I work on budgets, our military establishment today is threatened equally by the increasing healthcare costs that they have to bear as much as the domestic sector is. And my final observation before we introduce the panel is influenced by two recent polls. One just released yesterday by Pew, and the other released last week by Kaiser, and I think Tricia Newman yesterday mentioned this poll. Both also combined, once again, with the President's second inaugural address. And all this leaves me very unclear as we enter this panel, let alone as to whether this panel can find consensus, let alone the political system itself. Remember what the President said in the second inaugural address. Quote, "We must make hard choices to reduce the cost of health care and the size of our deficit. But we reject the belief that America must choose between caring for the generation that built this country and investing in the generation that will build its future." Now, for conservatives, those are very difficult words to translate into anything other than tax increases if we are to truly reduce our debt and deficits in the future. The other, the Pew poll, just released yesterday, very disappointing to me. And that was, it finds that for the first time since the question has been asked, beginning back in 1958, a majority of Americans, 53, 54%, believe that the federal government threatens their personal rights, and only 20% say they are content with the federal government. Tie that to the final poll from Kaiser that was mentioned yesterday, and digging down to it, found that the majority, close to 60%, want no reductions in Medicare. And by the way, this is true regardless of political leanings. 66% Democrats say no reduction, 56% independents, and 50% Republicans say no reductions. So even if this expert panel and NASI experts out here could agree with what reforms should be adopted to control costs going forward, the most difficult issue will be convincing the American public those reforms must be adopted. And without grassroots support or strong presidential leadership, any consensus on reform, I fear, is for naught. As David Wetzel told you yesterday at his luncheon, we don't have a gap between policy and reality. We have a gap between the public and reality. So with that, let me introduce the panelists who will tell us how we're going to find that consensus in this environment, beginning with Joe Baker, who is president of the Medicare Rights Center. And Joe has been there since June of 2009. He is a member of the Institute of Medicine's Board of Healthcare Services and Committee on Geographic Variation in Healthcare Spending and Promotion of High Value. What a long committee's name.
I didn't dream up that title.
Then he will be followed by Lynn Nichols, very familiar to many of you here. Lynn is the director of the Center for Health Policy Research and Ethics at George Mason University, and previously Lynn was director of the Health Policy Program at the New American Foundation. And finally, last but not least, Tim Trysla. He's a partner in the healthcare group at Alston and Bird, and previously served as a senior policy advisor at the Center for Medicare and Medicaid, CMS, and I first knew him on the Hill as a legislative assistant to Congressman Bill Archer. You have their full bios, and following their remarks, we will have ample time for you to ask questions. And with that, let me turn it over to Joe. Joe?
Okay, so I have a whole slide presentation that, even though I'm sorry we put it I know, but I'm not going to do it just because we've gone through a lot of it already, and I think it's interesting to look at it in the context of Kaiser Family Foundation data, and really where I come at this from is from the beneficiary standpoint, and that doesn't mean, okay, I'm right, I'm holier than thou. Just that, my concern is, of course, the majority of people with Medicare, vast majority are relatively low income, certainly fixed income, low assets, and one of the reasons that they and their families, because when we deal with the 50,000 or odd people that we deal with every year on our helpline, directly with people with Medicare, we really see Medicare as a family program. It's really one where families depend upon it, and polling has, recent Kaiser and Harvard polling shows that people do see it as a family, something that has helped their family. And so I think that's behind, Bill, some of the support, if you will, some of the, overwhelming, we don't want to see a reduction in the Medicare program. I think the consensus that I started to see come out of yesterday was, and David Blumenthal, and I think as well Tricia Newman talked about it, and to a lesser degree Gail Walensky as well, is that we have a federal budget problem, and in that regard we have a Medicare problem, but we really have a health care cost problem. And as the president of a small not-for-profit organization, I will tell you our health insurance is unsustainable. So if Medicare is unsustainable, so is my health insurance. And if you talk to there's many individuals that I've talked to over the course of the last few years with individual insurance, and that's certainly unsustainable. And they have foregone a lot of other things and leveraged a lot of other things in order to keep that going. So I think when the Medicare debate is engaged and Medicare is described as a problem, there's some cognitive dissonance in consumers' minds because they see the Medicare program as a very positive program, as something that is much more stable than anything that they've had in their lives to that point, in the sense that they understand that employment provided insurance is employment provided, and if it goes away they have nothing, and this is a guarantee. And so they are holding on with fingernails to this thing. And you are going to have to grasp it from them in a big way. And so I think that they're making pretty rational decisions in looking at this. Everybody wants the budget, everybody wants, why should consumers be any different than pharmaceutical manufacturers or hospitals or any other vested interest in saying, yeah, I want to decrease the deficit, but not on my back, So they're actually acting, pretty intelligently. Pretty assertively in many of the, as we heard from last night in our speech, in election cycles, saying, hey, I like that candidate in the House race that is, protecting my Medicare, and so, or my Social Security. So I don't think they are, out there looking for a handout or out there doing anything that anyone else in the healthcare, in this medical industrial complex, as I think you rightly describe it, is doing. I think they're acting in their own self-interest, as well they should be, and that's God bless America. I think there are, a couple things also that I took out of yesterday. One is the extent to which many people spoke about Medicare as, certainly maybe not as nimble as it should be, private insurers being more nimble in many instances, but as Medicare being a leader and a leverage, a way to leverage new policies. So certainly the ACA, I agree, there's some consensus, there is consensus, okay, let's move forward on this. Certainly I just came back from Phoenix, where I was meeting with and doing presentations on consumer engagement with Premier Healthcare Alliance, which is, of course, a nationwide alliance of hospitals. They are raring to go. They are with the program. They are really on this in a big way, and I think they're smart because they'll be the winners as opposed to other hospitals or systems that aren't moving ahead quickly and aggressively. So I agree with that. And I think consumers as well see the irrationality of the way healthcare is provided, and to the extent that they're listening to the ACA, now as providers, I think, get on board, they will help communicate some of the the better parts of the ACA and how it's supposed to work. I think we will start to see some more public support for the ACA if now, and that that goes against the submerged state over here, because many folks will say, oh, well, Premier's doing a great job, or, my hospital's doing a great job, but the federal government didn't do that. They did that, But once again, would we have prospective payment system for hospital care if Medicare didn't do it or didn't implement it in a big way first? Would United Healthcare have done that? I don't know. I mean, probably not, because then everybody would have moved to Aetna, because the hospitals would have said, we're not taking United anymore. So, I mean, I think you do need that leverage point, and so I think Medicare will continue to be a kind of an important beacon in that regard, and certainly it is rolling out many of the healthcare delivery system reforms that I think there is consensus around. I think where it falls apart is CBO can't score it, and we can't get the $400 billion in savings over 10 years from that. So just to use my last few minutes to talk about, okay, well, as Joe Baker basically saying, okay, leave enough alone. I thought it was interesting yesterday when Gail Walensky said, there's not a lot of political capital to do anything because Medicare's not in crisis. Per capita expenses are flat. Medicare looks pretty good compared to private insurance, about controlling costs. Okay, we've got this deficit thing, but that's kind of abstract. When you talk about like cutting Medicare, everybody has this visceral reaction against it. So maybe nothing will happen. Well, that doesn't mean we should sit back on our haunches and not work on this. And certainly that's not what I'm saying. So I do think the whole idea of revenue is still in the discussion. I don't know that there's consensus about it, but it seems to be that, the old revenue thing that last year everybody thought, no, that's not going to go, or we're going to have one bite at that apple. It seems to me that that's still being discussed, and whether it's taxes or excise taxes or other kinds of revenue, yet to be decided. I think the idea of, we've talked a lot here, and, the question is, well, what's the consensus here and what's the consensus out there, because this is a kind of self-selected group of people. But that said, I was surprised, I was not surprised to hear Ted Marmer and others talk about prices. And I think that's an important discussion. I was surprised to not hear anybody talk about pharmaceutical pricing. Because that's certainly an area, still a small part of the chart and, what Medicare pays for, but once again, an area that has been under discussion and could be under discussion again, and it was in the president's plan, and if I remember correctly, to the tune of about $155 billion. So, I mean, we're not talking chump change there. I think also we heard a lot about comparative effectiveness, and that's something I think consumers are intensely interested in. David Blumenthal's story this morning about back pain and the back injections and infection, very telling, I think, and certainly I think there could be consensus, and the delivery system reforms and comparative effectiveness really are trying to get at that. And so hopefully the rollout of the ACA will purge some of that waste. That said, I do have concerns when you see the Choose Wisely campaign getting rolled out, and Chris Castle, on the front page of the New York Times and saying, lung x-rays before general surgery, aren't really recommended anymore. And then you have someone say, well, that should be between a patient and his or her doctor, which is not what she was saying. Of course, it should still be between a patient and his or her doctor because there may be a reason to do it. And secondly, that smacks of rationing. We got a problem. I mean, if the doctors can't get together and all say, hey, this is, a good thing, and then all of a sudden other interests are coming in and saying, well, maybe it isn't, that is our fundamental problem with delivery system reform. Seeing commercials from hospitals and other providers saying, oh, yes, somebody went to this other hospital and then they came here and they lived. Hey, I want my father and myself to be involved in the living hospital, the hospital where everybody lives. But, those are the interests that are competing against a kind of, okay, let's do this in a more rational way. And I think we have to understand that. I don't think there's a consensus on how to deal with that. But I do think, certainly those in the consumer community that disagree with us or me, but that competitive bidding and other kind of value purchasing is something that, constructed correctly, could get at some of those problems. And in addition, I think there's a lot of consensus about consumers need a lot more information in order to make these decisions. And I don't see, there are barriers to consumers absorbing this information in the context of medical care, panic and fear and all that great stuff that you don't have when you go buy a new cell phone, except for me. That's why I still have the BlackBerry from years ago. But in any case, I think that there will be a lot of work to, I'm concerned about one thing, in addition to all these other things, and that is that consumers aren't being brought along the way, say, providers are into, there's no premier conference for providers, to get them all gung-ho to go. And so that's a concern, I think, over the longer term. And I think some of the information that we got at lunch today about some of the simple strategies for informing consumers that we're actually kind of pulling back from is unfortunate, and I think is an object lesson in the fact that we need to provide more information if we're really going to ask consumers to be true partners in solving this problem. I think what the knee-jerk reaction to groups like mine and other consumer organizations is that solutions that get to shifting costs from either government to consumers or to states or to other entities, and not at that underlying problem of really getting at and decreasing healthcare costs themselves or making the system more responsive and hopefully cheaper, thereby cheaper, are going to be pushed up against, whether that's 65 to 67, higher premiums for the same benefits, cost sharing for home health care. I don't know that we're going to reach a lot of consensus on those types of things if we're not getting at the underlying problem of healthcare costs.
Thank you, Joe. Lynn?
Well, thank you, Bill. It's a privilege to be here, and I'm going to actually try to do what I was told to do on the phone, which is really rare, because we were told to say, how are we supposed to find consensus on Medicare reform? That's what I thought you'd think about that title. So anyway, I'll just launch right in and see what happens. First thing, seems to me pretty clear. We need to recognize all bad behavior is based on fear. Therefore, we need to think about how to reduce the fear in those that are screaming at you. But I will say that the condition for being part of a consensus-building conversation, which all of you in this room have been part of, and all of you in this room have also watched as it has not happened for, what, 4 years now at least, know that you got to first agree that if you're going to get to have a seat at the table, you got to agree to stop demagoguing. That should just be a condition. And by the way, if somebody continues to demagogue, you should quit talking to them, right? But if a Republican would agree to say, I'm not going to say their death panels anymore, and I know you got me on tape, but I'm not going to say that anymore. And if a Democrat would agree to say, I'm not going to say all Republicans are trying to kill the Medicare program. I know some would like to kill the Medicare program. I know some would like to go back to the 18th century. Personally, I like penicillin and ESPN, but anyway, some people would like to go back to the 18th century, but I'm going to leave them alone. They're not in this conversation. Forget them. The ones that matter are the Republicans and Democrats who are willing to do those two things. Those who are willing to say, okay, we're going to deal with this as a common problem. Second thing is to declare your specific goals. A whole lot of confusion is because people are not required to declare their goals. Now, there are some people, in my observation, who have a perfectly sort of bona fide goal of making sure that every human being in the Medicare program gets everything they need at a price they can afford, which for some of them would be zero. Other people have a goal of making sure that no taxes ever go up anywhere on any human being on the planet. Those are rather different goals. But it's really important to clarify in the discussion, and I would point out to you that, in fact, you could work a consensus around both those goals being in the room. Be hard, but it would be analytically useful to point out the implications of satisfying one goal versus the other, and then you can start to talk about how to build a consensus. So I would also urge you, when you think about reform proposals, I think there are actually 3 elements of every reform proposal that you should sort of, do the analysis of. Check it against this criteria. First one, what's your spending target? I'm an economist. I'm a simple guy. I think of things in terms of compared to GDP growth, okay? So what is your spending target? over time vis-a-vis GDP per capita. That ought to be a criteria. And, you know, that's a very important dimension. The second dimension is, what is your enforcement mechanism? How are you going to achieve a correction if the system doesn't generate your target? And the third thing is, who bears the risk if you fail? All right, now if you take those three criteria, or those three elements of every proposal I would submit to you, let's just take the two big ones on the table at the moment. One is premium support in the pure form, the Paul Ryan form, the form where we basically, eventually, you can argue about how fast, but eventually put everybody in a private plan, pick a spending target, and let the plans enforce it. Another mechanism that I would submit is on the table is basically the ACA on steroids. Let the IPAB come into being, maybe move up the year where the hospitals start, but let the IPAB come into being and you let it go for a while, see what happens. Those are two different mechanisms. I submit to you both of those very arguably polar proposals on the table each have these elements. They have a spending target, they have an enforcement mechanism, and they have a who bears the risk. Now, in the premium support view, in my opinion, the spending target in the Ryan budget's a little tight, but it's based upon his real goal, which is to make sure taxes don't go up. So, you know, you can relax that and make that spending target, in my view, much more palatable and, by the way, much more realistic. But you could, okay, so that's one point. On the other side, you got the IPAB target, which is baked into the law, which is, I remember correctly, and it's been a while, is GDP plus 1. Okay? And you know, that ain't too bad. You might argue that GDP plus 1 might be the right target for the whole program, and that GDP itself might be the right target for per beneficiary growth, but we can kind of quibble with that. But my point is, actually, you know, you can imagine having both those mechanisms palatable to the other side. And then finally, the third, who bears the risk? Now, here's where the real difference comes. In the pure premium support approach, the risk is borne by beneficiaries. And the reason for that is that they want to make damn sure taxes don't go up, and they believe, against all evidence, that health plans contain cost growth. And maybe, we don't know, maybe if you actually did say to the world, this is all the money you're going to get, you will adjust, surely adjustment will occur. But I don't think there's a recorded time in history when folks actually lowered prices voluntarily. So I shudder to think what might happen if you set that target too high, because the risk is being borne completely by the beneficiaries. On the other side, if you think about it, what if IPAB fails? Who bears the risk? Well, I submit to you, ultimately it's a taxpayer. Because ultimately, if IPAB fails, and Congress doesn't like what IPAB proposes, Congress can stop IPAB, but then what the hell are they going to do? Secretary has power under the ACA now. How long do you think that'll last? So fundamentally, what you've got here is a political valve that will always default to tax increases, which is precisely why the folks who think most about taxes fear that. Well, then I'll stop here in 2 minutes, I promise, and just say, look here, sports fans, it ain't that hard. This is not rocket science. All you got to do is acknowledge that everybody's got to bear the risk, because everybody's in this thing together. You got to have some on the beneficiary. Lord knows, I couldn't agree more with Bill. We missed a huge opportunity, and with Joe too, by the way. We missed a huge opportunity not to engage the patients more completely in the reforms that are being tried now by the Center for Medicare and Medicaid Innovation. Look at that ACO stuff. We didn't even allow an ACO to give a positive incentive to have a beneficiary agree to stick with a particular set of providers for a particular fixed time. And we know why that's true, because if this administration had proposed it, they would have been accused of rationing and death panels and killing grandma and all that other stuff, because they had not yet imposed my rule of no demagoguery. But now, you might have noticed, the election's over, at least for the president, forever, in fact, for him. So let's think about putting some stuff in there where the patients are more engaged. But the point is, the risk has to be shared, because that's the only way it's going to make sense. It's the only way it's going to be politically palatable. And that violates the pure Ryan version. But at the same time, the target growth rate's got to be real. And that target growth rate ultimately has got to be set based on how much in taxes you think we're willing to pay. and I defer somewhat reluctantly to my elected representatives on this point, but they are the ones who have to decide this. They have to weigh all these issues. I will, of course, point out that we are, you may know this, the least taxed entity in the developed world. We take 10 percentage points fewer out of GDP than than the OECD average. If you add both federal and state, 10 percentage points fewer than all of them. And by the way, we have a bigger military than all of them combined. I don't know about you. I have a television. I see the world. I want a big military, right? It's a dangerous world, and half of them are pissed at us. But I will observe, if you got that big a military and you take 10 percentage points of GDP less than the OECD, you are not doing much on a safety net. And is exactly why, of course, NASI exists. So I'm saying you can do a reasonable spending target, a reasonable enforcement mechanism, and shared risk, and you could build consensus. What I don't know is does Washington want to? And that's where Gail's wisdom is actually quite prescient. I would just say, in my opinion, leadership is telling your base they're wrong at a pace they can tolerate. And we have not seen leadership in the Republican Party for, I don't know, 20 years, 30 years. Think about it. On the Democratic side, 15, 20. We got to get leadership to get this solved.
Thank you, Lynn. Comments. I have a couple comments, but we'll go to Tim.
First of all, I think it's ironic that I'm on the left. That's right. That's right. Where to start? First of all, I want to thank NASI. The dirty little secret, one of the few new facts you may learn is one of the first fellows for NASI I was in the first class and was a conservative Republican. So probably shocking to many of you, but it's nice to be back with some family and friends about this, and they gave me my start, and I'm duly appreciative.
Tim, we bookmark them here.
That's right. All right, we got them surrounded. Let's talk a little bit about. I'm going to talk about three basic things, and I'm going to talk about process. I'm going to talk, since I'm the Republican spokesman, I'm going to talk a little bit about the Republicans and the direction they're going to go, and then I'm going to talk about middle ground and try to really solve the solution. If you hear from the panel, here's my one jab. If you got to stop listening to Democrats describe Republicans. It's the worst thing you could do is have Democrats, because you heard a lot about defense spending and taxes, but let's talk about health care and the solution. And the first issue I wanted to talk about is let's talk about the existing system. And this is also probably a message to all my Republican brethren. We got to talk about what we're currently dealing with. The average beneficiary, she's a widow, she's about 81 years old, and she's on a fixed income. She's got a system that pays for providers for doing more and not for doing better, and a system that largely, at least based on my experience at CMS, if you pay providers to do more, guess what? You get more. If you cut their rates, they'll even do more volume to make up for the rate. So it is, to some extent, we have to acknowledge that we have a problem, and we have to reorganize the incentives in the system, and that I think both parties can agree to. So, but I just want to say process counts here, and leadership counts. It's good that the Senate Budget Committee is actually going to write a budget for the first time in 4 years. I was joking to Bill that it's kind of shocking that I wish I would have worked on the Budget Committee where you only have to work 1 out of 4 years. But the fact is that those votes and those decisions are going to be important, and those vote-a-rama to actually have our elected representatives make decisions and go on record of these tough cases, I think will be healthy for the system. Now, do you think that the Senate budget process headed by Senator Murray and Paul Ryan are going to be able to conference and have a process and reconciliation to get there? I'm not hopeful, but at least we're starting in the right direction. What this has to start with is presidential leadership. Whether it be Simpson-Bowles, which, to many House Republicans, because it didn't take on a new $2 trillion new entitlement of Affordable Care Act, didn't touch it, wasn't probably a good starting point, or the president who asked for a commission and then ignored it. You really have to start with some good framework. Politics has changed since I've been in Washington. When I got here in 1990, if we had a payroll tax holiday, I'm guessing Senator Moynihan would have had a filibuster, because these were not taxes, these were contributions. And the left would have gone nuts in relation to that. And everyone has kind of walked away from any kind of accountability or responsibility on that side. And so I think it's incredibly important that we understand that both sides are going to walk away with being unhappy. If the president truly wants to lead, he has to leave with a 36% approval rating and really break some glass in order to do this and have enough trust on both sides for people to make tough decisions, because these are tough decisions, and so you have to first understand you have a problem. For Republicans, it's going to be incredibly important to first understand where we've been and where we're going and where we'd like to go. And that starts with Part D. You know, for those of us who worked on that, we're at CMS during the implementation and negotiation of that. You know, it's interesting, and we worked hand in hand with the Medicare Rights Center, but I'll just tell you, for Republicans, that's a program that came in 43% below budget. If you look at some of the quotes from 2005, and this is from the USA Today, most seniors don't understand the new prescription drug benefit. The plan won't, and they won't sign up. This is from Robert Hayes, your predecessor, Joe. Part D is a monster, and it's going to hurt a lot of people, and it's frightening. None of that has come true. And when you have a program that actually is below budget, and here's my message to my Democratic brethren. What we did in Part D is provided a much more progressive, we protected low income, largely due to the fact that Senator Kennedy and others were part of our negotiation. People don't remember that there was over 72 votes for Part D in the Senate. And Senator Kennedy endorsed that. And I think we'd have a different debate if we had Senator Kennedy still in our presence, because he understood these issues. You can reform, and I expect the House Republicans to have something very similar to what they proposed with Senator Wyden and Paul Ryan did, with systematic reforms, bringing, ensuring the accountability for future beneficiaries, people, whatever you want to call it, 50, 55, and above. You can build a better system that's more accountable to patients, that works better for quality, and brings that message of competition down. When you have a program that's already proven to be something that's been sustainable, has got wide popularity from seniors from the prescription drug benefit, and if you talk to folks who are back there, especially on the left, and to some extent, we should have John up here. You know, I'm sure the AARP had a lot of pressure at the time to say, why are you backing this? Because I know Bill Novelli told me at the time, we don't want to back, you know, the Democrats are saying, you know, hold off, we'll give you something better. And he said, no, we're going to work with the Republicans to reform and improve the program. It's the first time in over 30 years that program been added a substantial new benefit. And so let's talk about what's the doable. And let's go back to that 81-year-old beneficiary, and I got 5 minutes to talk about it, but you know, where we can see some consensus. First of all, you saw Senator Hatch put out some reforms, and I think Jay mentioned this the other day. He said, you know, for the first time you haven't seen Democrats telling him he's trying to kill the program. He put out, I thought, some pretty responsible individual ideas, not total solutions, but Republicans want to have a conversation about these problems on a reasonable basis. And so, you know, paying doctors not to do more and paying them for better, moving to a more episodic payment system, everybody agrees this is a good place to start. The problem with the driving down costs, and this is what, there's nothing affordable about the Affordable Care Act, and there's nothing that dealt a lot with cost in that. Whether you want iPad that is an illusion or because it's just another form of provider cuts, we can't do this solely on the backs of providers, which I think you have right now. The president saying we need to cut Medicare more on the providers, and Republicans saying, no, let's reorganize the incentives in the program to have a more sustainable system. And so one of the things that we need to do is kind of look at that. How does the present system work for our current beneficiaries, and how can we build that in the future in a two-part step? So, you know, one of the first steps I would suggest, if you look at some of the Hatch reforms and even Simpson, Bowles, and others, is the first time that Part D, they provided catastrophic health care coverage for prescription drug costs. The first time in Medicare, you actually have a stopgap where seniors can understand that they won't be bankrupt. Remember when we were choosing and having the demagogue that Republicans, you know, the seniors are not eating because of the prescription drug costs. And I know for the fact that Medicare Rights Centers work with those seniors every day. The Part D program has a very generous benefit and provides catastrophic coverage. We can do that now for all seniors by consolidating and making, we've added so many different programs, piecemeal, DRGs, everything else with different co-pays. None of it makes sense to seniors. It doesn't work for seniors. And you notice I didn't say Medigap reforms because I don't think that that's a really, you can't really do that, and you don't get any savings because you probably have to grandfather everybody. But we have incentives to over-consume in our healthcare system, but we also can protect beneficiaries. There's ways of doing the eligibility age, and so let's talk about the futures program. Raising the eligibility age so it protects some of the low-income seniors, and I think the Kaiser Foundation put some ideas out there that may or may not work. And then, certainly people have some general discussions around CPI and some other things that economists at least would say are more accurate. I know that's a backward way of saying we're going to cut benefits, future Social Security benefits. But the fact is that these programs are sustainable. I mean, for me, there has never been a budget debate without a health care debate, and Bill Hoaglands of the world know that. And so does anybody else who's seriously looked at the budget. And so when I looked at the Affordable Care Act and other reforms without addressing cost in the system, if you care about the environment, if you care about education, if you care about safer roads, you better care about health care. Because it's a Pac-Man effect where healthcare is slowly squeezing out all of our priorities of our government, including defense. And so addressing that head on and coming to sobering realities in a democratic process where there is a president that will lead and leaders that can trust each other will result, I think, in a blockbuster opportunity, because the only way we have to turn this around is the president has to take his eye off the ABJ agenda, anything but jobs. If he focuses on unleashing the economy, getting the American people back to work, we have to get a budget process in place. We have to make these tough decisions, and for me, it always starts and stops with health care. And so we need to focus on what we have in front of us, build a better system for our existing Medicare beneficiaries, and provide a sustainable program for our future beneficiaries. Thank you.
Thank you very much. I've got 3 quick questions for the panelists that I've been kind of thinking through as they've been discussing, giving their remarks. Please think about what you want to ask these fine gentlemen. Let me work down the line here, first of all, beginning with Joe. Joe, you talked about the importance of this to families and individuals out there, and clearly that is an issue in terms of Medicare. It's a benefit to a lot of people. But let me just ask you, Joe, does the American family, or does the American public, maybe I should say, understand that their government, just like their family budget, this is kind of picking up on Tim's last point, like a family budget, when they have to spend more on health care, they have less to spend on food, transportation, education, of course, unless their incomes increase to keep pace with the cost of health care. So just like the federal budget, those things that I think are important, particularly for social services, we haven't even talked about disability issues here, the issues associated with the dual eligibles, and a lot of that is social services, that gets squeezed terribly hard in the federal budget. That's the area that budgeteers call the discretionary portion of the budget.
Right.
Does the American public understand there is a price to be paid here in other types that Lynn's the great economist up here, there are always so many resources out here.
Right. I think they do. In a fundamental way, I think people do understand. I mean, you see the polling about the deficit, and people are like, "Yeah, we need to do something about the deficit."
Yeah, but they always go to foreign affairs as the
well, exactly. It's foreign affairs and federal workforce, and all those waste, fraud, and abuse, and those kinds of things. So I mean, I do think there's a lot of education that has yet to be done. I don't think we've had the leadership of folks, doing exactly what Lynn lays out. Who bears the risk? I mean, how are we going to share the risk amongst different interests? And as I said, if you look at it from your standpoint of the military-industrial complex, there are a lot of interests in that, and consumers are a piece of that interest. So they're looking at, okay, well, who else is getting soaked besides me? I mean, are those things being shared? I don't think they either see that because it's not explained to them, or, you know, when you, and I would agree with Tim that there's a lot of simplification we could do of the Medicare benefit. But when that is proposed as we're simplifying and rationalizing the Medicare benefit, oh, and by the way, you know, there's a significant federal budget savings associated with that, and meaning a lot of cost is being shifted to consumers, rather than, hey, you know what, we all got to, you know, World War II, we've all got to share the sacrifice. We need to build that high-speed rail. We need to build that high-speed internet, and we're going to, you know, raise taxes a little bit over here, and we're going to increase costs for people with Medicare over here, you know, because we need more money, and we think that's a fair way to do it or the right way to do it or provides the right incentive. If that was the conversation, rather it's rationalizing and simplifying, and we could do a budget neutral, but we're not. But we're still going to use the rationalizing and simplifying words. People pick up on that. I mean, not just the Medicare Rights Center saying, "Hey, did you hear this?" But you know, in their look at it, they say there's something awry here. So I think it's really articulating what is that shared sacrifice, if there is a sacrifice that needs to be made, and how it's made. You know, and how it's made either intergenerationally. Because once again, you know, we hear from you know, a lot of 50-year-olds or 40-year-olds. You know, I'm not so much even interested in making sure Medicare is there for me. I do want that, but I don't want to be sending my mother a check for $300 a month. I'm already sending my kid a check for $1,000 a month. You know,
the sandwich generation.
So you know, it's that. I think that is I think. We're not talking to people honestly about what we're actually proposing in some of these instances about bearing risk, and they pick up on it.
Yep.
They've got it, you know.
Okay.
And so there's a lot. That's, I think, a lot of the pushback
Okay.
in this.
And I think we can get a consensus between the three of us that we could do some of these protections, but protect that low income and
Yes,
do
I
it in a
agree.
way.
Yeah, I think that's
So we
absolutely
solved
right.
one
Yeah.
thing. Nice
Let-
work.
Right.
Let's go.
Let me pick on my friend Lynn Nichols for just a second here. First of all, Lynn, I was just doing a little quick calculation here about leadership and no leadership in the Republican Party. I think 1998, that's only 14 years ago, Bob Dole, even I'll get George Mitchell, Bill Clinton, there was some leadership there in that period. Of course, I'm angling toward my old boss, Senator Domenici, too, at that time, but there was some leadership there. We don't have to go back that far, but that's not what I wanted to hit. What I wanted to ask you, Lynn, and I agree with you.
On rare occasions, I would agree, it did occur.
Your first criteria, what's your spending target? I love it. So, okay, so let me just ask you, now, let me be the first one to say, I agree with what I heard yesterday, what everybody's discussed. This really is total health care spending, not just Medicare.
Right.
It's not going to do any good just simply to shift the cost out there from the public sector to the private sector or vice versa. So, but let's look in total health care spending. What's your, I think I know what the answer will be. What's your spending target, Lynn? 18%, 17%, 22%?
So I start from the premise, and that's a great question. I start from the premise that the people who run the system, people who actually run hospitals, who actually run the big physician groups, who actually run health plans that pay attention, and that's not all of them, but a lot of them do, they know that we now spend, let's just say, a lot more than we have to spend to accomplish the objective, the outcomes we're getting now. So I think we should have as a target GDP plus 0 for per capita spend for a decade. Let's put it, here's how I get to there, okay? You take the IOM and those kind of guys, and they say roughly 30% of what we spend is not adding to health. Okay, so we have been growing roughly 3% faster than GDP per capita for roughly 30 years. So if we were to grow flat for 10 years, and by the way, that only requires taking 10% of the waste out per year, but each of those 10% chunks is 3% of spent. So if we were able to accomplish that for a decade, Bill, I'd be retired and we could all get drunk. I mean, I honestly believe, and that would
Nirvana.
mean we'd have flat GDP as a share, but I don't really care about GDP as a share. I don't think GDP as a share is some magic number.
Okay, good.
But I do think that we have enough, I'll just say it, ineffective spending in the system now that we could squeeze enough to get GDP.
For us budgeteers, it's music to the ears, I guess, because boy, that's an easy scorable kind of a
There you go.
way to go.
My gift to you.
But I would go to your last. How do you enforce that though? Becomes a little bit of an issue. But we'll.
Will you want me to answer that too?
Yeah, sure.
101st Airborne comes to mind. I think, look, you're going to have to get serious about targets and consequences, right? And the reason I like the IPAB structure, not that I like every feature of it, Lord knows.
And Lord knows how we'll ever get them appointed though.
Well, it would help if we'd stop demagoguing. But anyway, the reason I like the structure is there's an explicit target, there's a trigger to when they're supposed to come into being and do their business. That is to say, come up with a proposal that will get the program back on the target. And there's a mechanism that says if Congress doesn't come up with something that the independent actuary scores as equally effective, then what IPAB has put forward will happen. Now let's just, give me 30 more seconds. What are they talking about? What is that about? It is about taking the payment reform things that are going on right now, by the way faster in the private sector than in the public sector.
Yeah, I agree.
And that's the good news, right? These ideas are not bad ideas. As Tim said, we all agree on realigning incentives. It's the best way by far to get people to get where you want them to be. You make it in their self-interest, so you pay them differently. And the private sector's figured this out, and so why not just have more of that? And not try to leave it all to health plans, and not that I don't think health plans are effective, they're always going to be part of the program and should be, but they don't have the market power.
Right.
And that's the problem.
I now work for a bipartisan policy center, so I have to be equally fair here. So, Tim, I have to ask you a question, too, before we turn it over to the audience and their questions. And that is, I looked at the Hatch list of the press release, I think, increasing the age of retirement. First of all, let me just make one quick observation. Most proposals, and even the proposal that Paul Ryan had last year in terms of the premium support, which didn't kick in for 10 years. We basically have a pact, it seems to me, and this may not work in the current budget environment, that we're not going to impact current recipients. The difficulty with that is that means it puts it back on providers. But most of the major fundamental structural changes are out beyond the 10-year budget window. But Tim, let me just ask you, the one that I was surprised that you mentioned, you said that was not a good proposal, which I have heard discussion about here, and that would be to eliminate first dollar coverage. If there's an overutilization, if the issue is to get the consumer to be more aware, why wouldn't we eliminate first dollar coverage in the Medigap programs?
Well, let me put my comments in context, and I want to make a comment on iPad. Number one is, let me talk to Medigap in general. Personally, I think that we should do that in the future reforms. I think that's doable. The problem is that for what I think was going to be possibly doable this year with presidential leadership or some of the things I mentioned, more episodic payment for physicians, starting, I expect reforms with a small r, but important reforms that we can put in place both for now and in the future. Medigap, you could probably do that with a 10-year window if you're going to, because of the budget concerns, in order to not have the disruption, in order to totally submarine the bill, you'd have to grandfather all the existing Medicare beneficiaries and all your savings go away. So it was more of a political reality. The only problem I have with iPad, you're paying people, 10, 11, 15 people, $160,000 a year, they're full-time employees, to make decisions, for example, to maybe have some incentives for doctors to use generics in Part B, or other kind of opportunities to not necessarily have reimbursement drive their practices. I mean, you see all kinds of perversions when you sit in CMS, where if you're in an academic center or a hospital center, they're slapping a patch for anti-nausea, but when you go to the community, you're getting that administration for the anti-nausea drug because the doctors are being paid. So there's a lot of things you can do that doesn't take profiles and courage, and it doesn't have to have these unelected representatives to do it. I just wish we had elected representatives like on the Ways and Means Committee, on Commerce, to dig into these issues and systematically reform the payment system in order to naturally have these outcomes come out to the betterment of the patient.
And that's why they gave it to iPad.
Yeah, well,
Thank you. I'm not sure we reached any consensus here, but this is an opportunity for any of you who have questions. And I would ask, because we are running a little time constraints here, that we ask questions and not give speeches. I appreciate it. Yes, sir.
Larry Seidman, University of Delaware.
Hi, Larry.
I was glad to see Bill say we've got to look at health care costs for the whole economy, society, not just Medicare. So suppose a practical, non-ideological person said, we're at 18% of GDP for total medical cost. Is there anybody else that does better? Well, we'd look around and they'd say, well, as a matter of fact, all the other countries do better, 12% or less. Well, what do? Do they use premium support? Do they use market competition? Do they use high deductible plans? I wish they did. I'm a professor of economics. I love what the free market does for thousands of goods and services. But after 30 years, I've given up feeling it can be worked in medical care. The other countries all use single-payer bargaining power, and my goal would be to cut in half the gap. They're at 12 or less. We're at 18. How about 15? How can we do it? Do more of what they're doing, which I think would be Medicare for all, gradually phased in, with the single-payer bargaining power and government and regulation that they all use until somebody can show something else better really works. Theirs has been working for several decades.
Lynn, Tim, Joe, Medicare,
So all
Medicare
I would
for
say
all?
is, very quickly, Larry, and you've heard me say this before, it's a good idea. But I notice that it polls way better on the coasts than it does in the middle of the country. And I think that's because if you're on the coast, you know that if it doesn't work out, you can get away really fast. What I mean is, America does not trust government enough to give them the power to do what you want. And therefore, our inefficiency is baked in. What we have to do, I think, is within the confines of our values, figure out how to make incentives smarter, and that's our only hope. I mean, and by the way, you're going to have an experiment. Vermont is headed toward
Vermont's
it.
our hope.
So we're all sending every young economist going to write dissertations on how it worked out in Vermont, and in 5 years we can
Right.
maybe have it proof. But I will promise you, my gentle friend, whatever the outcome in Vermont is, Texas ain't going there.
Yeah. But I mean, I would say one thing, and that is what those countries have, whether it's single payer or not, is a spending target. And I think there is some, or global budgeting or whatever you want to call it in those contexts. And so, that is something I think we can learn from them. While I don't think the Medicare Rights Center certainly has taken a position on whether it's 18% or +1 or whatever, I mean, the idea of a spending target, the idea of the IPAB, I mean, let's remember the IPAB in and of itself is a compromise. I mean, many liberals, many folks that, swallowed very hard and still think it is, not a good thing. Others of us said, well, we need some constraint on this. And, the biggest problem that I have with the IPAB is that it's not system-wide. It's just on Medicare.
Let's let the president of NASI get in.
30 seconds on this, I mean, come on. The single payer discussion, number one, if you think healthcare is expensive now, wait till the government, wait till it's free. What you see in Medicaid and everything else, all these abuses and all that fraud and other things are probably permanents and creations of the federal pricing system and a lack of oversight. We don't run it well. We don't know what's going on in Medicaid, and that's my biggest criticism of Affordable Care Act, because you're already putting more seniors on a broken system.
Larry?
All right, I just, I wanted to ask on the areas of consensus where there appear to be consensus around, revising the payment mechanisms in the system, creating incentives for efficiency and quality and outcomes and stuff. How far can we go really pushing major changes in the incentive structure in the program without changing the structure of Medicare itself? And because we have the A, B, D silos that really work across purposes in many ways. We have IPAB, which is limited in its ability really to get into the mix on this because it can only really go into the areas that are open to it under the Act, and it's also siloed. So it can only draw down on payment in particular silos without getting at you know, the underlying issues, and it only addresses Medicare. So the question is, you know, for all of you, is there consensus that there needs to be structural reform in the Medicare program to kind of create an environment in which integrated delivery systems and all of that can really work, or is that an area of disagreement still?
Here, let's work this way. Tim, Lynn, and Joe.
I don't think so, but that's exactly where I think the Republicans are. I mean, we are sitting there saying we have a 1965 model, no matter how much we try to upgrade it and put new parts and whatnot to make it drive faster and be safer, it can never be safer and as efficient as a 2013 model. You don't have these silos when you hand this into a Medicare Advantage system and other things. So you would never devise the system if we started from scratch today to look like Part A, B, C, D, and the alphabet soup that we have today. And so that's the exact premise of why I think the President is still trying to defend the old system, and where we should have a collaborative on a bipartisan basis with mutual trust to devise a better system for future beneficiaries that doesn't have all these perverse incentives.
So I think it depends on what you mean by structural reform. If what you mean by structural reform is complete health plan taken over, no, you don't have consensus. But if what you mean by structural reform is, can we make the benefit structure more rational? That is to say, have one deductible and smart co-pays and value-based design, sure. If what you mean by structural reform is, can you think about changing the accountability locus from 8,000 CPT codes in Baltimore enforced by bureaucrats at the end of a phone versus having providers agree to share risk among themselves, and by the way, share the risk with the taxpayer, and by the way, build in incentives for the beneficiary to choose the right providers? Hell yes. That's structural reform I'm totally for. What I'm against is structural reform that locks it into one model. I agree, 63, 65 is crazy. We'd never do ABCD again, but why give it all to health plans and say good luck? I think what you want is, if you did away with what Medicare fee-for-service can do now on the incentive changing front, you would be hostage to the smaller market share that most plans have, which is why they complain so much about hospital prices out there. The only hope we got, Larry, of getting incentives really changed is if a critical mass of spending for a given provider group is actually saying, hey, we're going to change the way we pay you. Next thing you know, United, Aetna, Cigna, they're all agreeing. They may argue about conversion factors, but if the structure of payment is the same, that's how you change behavior. So I'm all for structural change. I'm just for doing it smart and sharing the risk.
Yeah, and I'm not. None of the proposals hand everything over to a managed care plan. We're just talking about competition.
Joe.
What he said. I mean, I think I agree with Len here, and I think, once again, we're putting a lot of chips down on the ACO model, you know, and on these new integrated delivery system models, and you know, if they don't work, we're in a bad spot. And I think as I said, I was with Premier earlier this week, and they are on the ACO model. They are really taking it, you know, to heart, and so, you know, call me Pollyanna, but, you know, I'm putting some faith in that. I think ABC, you know, D should be rationalized. I don't think we're going to do it in a consensual way anytime soon, one way or the other. So I'm hoping that Len is right and that we get the result we want even without doing that, and then maybe we can back into the rational plan.
It's the American way. And we have a question from the pharma industry, kind of.
Oh my gosh. I was actually about to say I'm Nicole Tepe with Eli Lilly, and I'm asking this question in my personal capacity, but I obviously just to discuss. It's about the cap. You know, there was a discussion yesterday, and Jane was part of it as well as Kavita Patel, and this also ties in with Tim's point about Part D. You saw really good results in terms of cost under Part D. There wasn't a cap. I understand from a budget scoring perspective the need for a cap, although there's also been some really good points made with respect to the desire to make it a system-wide cap rather than a Medicare-only cap. And as we talk about consensus, I just wonder if that's really realistic given the proposals that are floating around in town that are really very Medicare-focused. So given that, if in fact the assumption would be correct that we're talking about a cap within the Medicare proposals, could that potentially cut against the interest of actually lowering costs if in fact something like a Part D model was actually more successful?
Thank you. Joe.
Well, I think there is a real question about setting a cap. Does everybody, you know, spend up to the cap? You know, I mean, certainly, and, you know, can we do better? And it's kind of Larry's point, too, is like, why don't we set it at 14%, not 18%? I mean, I think the more, and of course, we heard David say earlier, you know, I don't have an enforcement mechanism for my cap. It's a kind of aspirational thing that we can, you know, and then we'll hit you later if you don't hit it or something. I don't know. I think, you know, the IPAB has a cap. You know, I mean, and it's on the Medicare program. It's what we have, and so I say work with it and see. And you know, I would agree. We've got enough money in the system. We're just not allocating it appropriately. You know, when you hear about the back shot that doesn't work and then everybody gets sick, and you know, and so, and there's lots of other examples of that. So I do worry about the spend up to the cap part. So maybe the solution is just to stick with 18 and see how we do. At the same time, maybe we should be looking for 14. But I think we've got to commit to something and see if it works, and then ratchet back if we feel like we need to, or push it up if suddenly there's some treatment that kind of blows through the roof, but is the right thing for everybody to have.
Leonard?
So the right word is target, and enforcement mechanism is where you get into hard or soft and all that. And I would submit what IPAB actually is a target, and what the Ryan budget was a cap, because he said this is what we're going to grow at, and that was that. So I would strongly endorse the version of the Part D model where, why did we get what we got? Because we had competitive bidding. There's nothing wrong with having competitive bidding be a major part of all of these incentive realignment. In fact, you should do that. And that's why the target's the right concept as opposed to a global budget, because the target allows you to come in under. I will also point out that the way better than predicted was vis-a-vis the CBO score. Rick Foster always had the cost way lower. He wasn't allowed to tell Congress what his estimates were for reasons I still don't understand. But nevertheless, he was right on the target. So if we'd had his thing in the public domain, they wouldn't be under budget. But anyway, the point is this. You can have competitive bidding, which you should have. That's how you beat that cap, if you will, or that target. And I think that's what you want as part of these.
Budgeters and Congress can, the Affordable Care Act says you can write anything, is a proof that you can write anything in that makes sense to CBO. I mean, you got a illusionary class program that counted premiums, double counting Medicare cuts to pay for new entitlement programs. I don't see this as a viable issue. Second comment is I don't encourage Republicans to take this up because we often too much talk about budgets and not about patients and benefits. And again, I'm not a big fan of these illusionary caps that have bureaucrats, having been one, to come in and kind of deliver those hard decisions. It seems somewhat undemocratic to me that we're going to decide certain ages aren't going to get transplants and whatnot. So it is going to be difficult.
Yes, sir.
Adam Jutha, I'm a student at the University of North Carolina, Chapel Hill. So we've talked a bit about realigning payments and really discussing the shift in the way that we provide reimbursements for Medicare as well as for other insurance plans. My question then moves forward into looking at pay-for-performance models and the way in which those essentially work and if they are effective or not, and where the best medium to actually put those ideas forward is. Some studies have come out that really suggest that pay-for-performance in hospitals doesn't really work, and in fact creates additional racial and ethnic disparities. So with these studies that are coming out and with this research continuing to go on, where do we go from here in terms of determining what the best approach is for overall cost reduction and cost containment in healthcare?
Anybody?
Well, I tell you, personally, I think we kind of we just kind of started this pay performance discussion and putting incentives for Medicare just not to pay all providers the same and actually looking at their outcomes. And so I think, again, the number one cost driver is the physician's pen and how she's practicing medicine and whether we can change that decision-making process as well as informing patients. And so I think on the margins and in small kind of clinical vignettes, as better education comes on place, we can make a huge difference. Classic examples, certain patients with heart conditions are discharged. 3 things you need to do that are pretty important is to make sure that they get a brown bag consultation, a follow-up visit with their doctor, and that they're weighing themselves and calling into their nurse every day to see if the water is built up in the heart. You can reduce hospitalization by 40%. And I don't know if there's a racial component to that, but the fact is that that's a realignment that I think works for all patients. And so that was what we were incentives. Measuring hospitals now for hospital-induced infections. But they're very small reforms. The problem with Washington is everyone wants to write a wand and say we're going to reduce costs in certain ways, whether it be a budget cap or we're going to cut hospitals by, market basket XYZ. Cutting costs is very difficult, and, it's going to take a lot of commitment on both sides of the aisle.
I would submit that we need to be really careful, especially those of us in the research community. Almost every, if you will, literature review of almost every intervention in the history of civilization would show that on average it had no effect, right? Because it turns out some schools work, some schools don't, so let's just abandon public schools. At the end of the day, you got to look at what works and see does it spread and try to encourage the conditions under which it'll spread. That's all Washington can do, is create conditions under which it could spread. So what I would observe is that there's something like 3,400 medical homes out there now that private plans have contracted with. Not every medical home is going to reduce hospitalization by 20%. But hey, if we just get 2, it'd be pretty good. And so what you're going to see is the ones that figure out the 6 things that really matter, like the 3 things, they're going to adopt that more often. That's going to spread. And that's how you get from here to there. It's a big old country. It's going to take a while.
But we have to incentivize providers. I mean, every hospital administrator knows how to reduce costs. If you want to reduce hospitalization, they can do care transition. They can empty a few beds. They can manage to whatever you're measuring. So it's a very complex issue.
And the Commonwealth Fund will get the last question and tell us what the consensus is.
Thanks. I hesitated a little bit walking up to the microphone on the right, but I guess it's your left, so it's okay.
Yeah, it's okay.
Let me propose a different way of thinking about this, because as long as we're talking about who does what to whom, I don't think we're going to get very far in the healthcare system, whether it's arguing about whether it's providers who get shafted or beneficiaries who get shafted. I don't think that's the way to think about it. And another thing that has always troubled me when people talk about health reform is they talk about a shrinking pie. You hear provider groups especially talking about blood in the streets because you've got a shrinking pie. If you looked at the graph that Dave Blumenthal put up this morning, you see that health spending is projected to rise from $2.9 trillion in 2013 to $5.5 trillion in 2023. I think only in healthcare would a 75% increase in spending over 10 years be called a shrinking pie. I think another way of thinking about it is to think we're projected to spend $42 trillion over the next 10 years. And I'm old enough to have trouble with trillions versus billions. I remember when $1 billion was a lot of money. But if we reduce that to GDP growth, we would be somewhere in the high 30s, 38, 39 trillion dollars over the next 10 years. I think instead of talking about how we're taking $3 trillion out of the healthcare system, instead we ought to talk about taking $39 trillion and figuring out, sitting down with consumers, providers, the government, private payers, everybody involved, and say, how can we spend $39 trillion over the next 10 years and get the kind of healthcare system we want instead of what we got?
Thank you. I think that's the purpose of trying to find consensus, is it not? But does anybody have a response to?
You go, guy.
Thank you very much, everyone. I appreciate it. Thank you. Let's have a report. We have